Welcome. Today we take on gallstones. About 10% of people in Western countries have them. Most will never know. Our whole job is to work out which patient in front of us is the exception. We will follow one woman from her first attack of pain to the decision to remove her gallbladder. Along the way we build the mechanism, the stone types, and the natural history numbers that tell you when not to operate. We will also take apart the phrase biliary colic, because the pain is neither reliably in the right upper quadrant, nor colicky. Meet Renata. She is 44 and teaches 4th grade. In the last 6 weeks, she has had 2 attacks of severe upper abdominal pain. The second one was 2 nights ago. She has also lost 32 pounds in 5 months on a glucagon-like peptide-1 receptor agonist. Urgent care called it gastritis and started a proton pump inhibitor. It did nothing. So here is the question that runs through this entire video. Is this pain coming from her stomach? Or from her gallbladder? Hold on to it, because the answer is almost entirely in the history. Here is the plan. First we explain why bile makes stones at all. A 3-step mechanism that makes every risk factor obvious instead of memorized. Second, we separate cholesterol stones from pigment stones, and black pigment from brown. Third, we learn what biliary pain actually feels like, and what it does not. Fourth, we walk the workup, which is shorter than you think. And fifth, we make the operative decision, both for the patient with symptoms and for the far more common patient whose stones were found by accident. Now the attack itself. It began abruptly at 10 at night, about an hour after a fried chicken dinner. She points to her epigastrium first, then slides her hand over to the right upper quadrant. It was steady and severe. She paced the kitchen because no position helped. It traveled through to her right shoulder blade. She felt sick and vomited once, and it faded slowly over about 2.5 hours. Then it was completely gone. Notice how much of the diagnosis is already sitting in that paragraph. Now the background. She carries obesity and dyslipidemia and was recently started on a statin. She has had 2 pregnancies and took oral contraceptives in her 30s. She has lost 32 pounds in 5 months on a glucagon-like peptide-1 receptor agonist. Her mother had her gallbladder removed at 45. And there is no alcohol use, no hepatitis, and no prior surgery. Almost every line there will come back when we reach risk factors. Keep the rapid weight loss in particular in your pocket. Her examination is quiet. She is afebrile, heart rate 78, blood pressure 128/76. Her abdomen is soft with only mild epigastric tenderness, no guarding, no Murphy sign, no jaundice. And this is exactly what the examination looks like in uncomplicated biliary pain. Afebrile, with at most mild right upper quadrant or epigastric tenderness. The moment you find fever, or a Murphy sign, or jaundice, you have left this topic and moved into cholecystitis or a duckstone, before anything else. 3 words. Cholelithiasis means stones sitting in the gallbladder. That is today. Cholecystitis means the gallbladder wall itself is inflamed behind an obstructed cystic duct. Choledocholithiasis means a stone has moved out into the common bile duct. Both of those are complications of the first. And both are separate topics with their own workup and their own management. Today we stay upstream. A patient with stones and pain, and nothing worse. Yet, start with scale. Gallstones affect about 10% of Western populations. That is 1 in 10 adults sitting in your clinic. Of those people, 15 to 25% go on to develop symptoms over 10 to 15 years. Read that the other way around. The clear majority carry stones for a decade or more and never feel them, which is why most gallstones are discovered by accident, on a scan ordered for something else entirely. Remember that when you read an incidental finding on a computed tomography report, now the mechanism, and this section pays for itself. If you understand why bile makes stones, you will never need to memorize a risk factor list again. Every single risk factor on this topic is just one of 3 things going wrong. Bile has 3 players: bile salts, phospholipids, and cholesterol. The salts and the phospholipids are the solvent. They keep cholesterol suspended and moving. Cholesterol on its own does not dissolve in water at all. So bile is really a balancing act. As long as there is enough carrying capacity for the cholesterol present, everything stays liquid. Tip that ratio. And cholesterol comes out of solution as crystals. And remember, the gallbladder concentrates bile between meals, which concentrates the problem right where the stones will form. Follow the pathway. First, Cholesterol saturation in bile rises past what the bile salts can hold. That is supersaturation. Second, crystals form out of that bile, and in patients who make stones, nucleation is accelerated. Third, and this is the step people forget, the gallbladder is hypomotile. It does not empty briskly, so those crystals sit in a stagnant pool instead of being flushed into the duodenum. Give that months to years, and the crystals aggregate into a stone. All three hits together, not any one alone. Now watch the risk factors fall into those three buckets. The first bucket pushes more cholesterol into bile. Obesity, dyslipidemia, estrogen and oral contraceptives, clofebrate. The second bucket slows the gallbladder down. Rapid weight loss, total parenteral nutrition, pregnancy, octreotide. The third bucket removes bile salts from the circulation. Ileal disease or resection. Less salt returns to do the dissolving. And notice rapid weight loss appears twice. It mobilizes cholesterol and it stalls the gallbladder at the same time. Some risk is fixed, female sex, age over 40, and ancestry. Higher risk is described in South American, Central American, and Native American populations. Pregnancy belongs here too, both because of the hormonal load and because the gallbladder empties poorly in pregnancy. Now count them for our patient. She is a woman, she is 44, and she has had 2 pregnancies. 3 of the 4 before we get anywhere near her medication list. This is a common disease in a very common patient. Medications push this risk in both directions. On the left, oral contraceptives and estrogen, clofebrate, octreotide, and total parenteral nutrition. Glucagon-like peptide, 1 receptor agonists, are also flagged, with a question mark against them. The signal is raised, not settled, which matters for our patient. On the right, statin use is associated with a lower risk of symptomatic gallstones and of cholecystectomy. So Renata is carrying one drug that may raise her risk, and one that may lower it, and she formed stones anyway. Here's the table worth knowing cold. 90% of gallstones are cholesterol stones. They come in 2 subtypes. Mixed stones contain more than 50% cholesterol and are typically smaller and multiple. Pure stones are 100% cholesterol, larger, yellow to white in appearance. The other 10% are pigment stones. Black pigment stones are unconjugated bilirubin and calcium. Brown pigment stones are bilirubin that bacteria have deconjugated, precipitated with calcium, and they live in the bile ducts. Now the cause of each. Cholesterol stones come from the 3 hits we just built: supersaturated bile, accelerated nucleation, and a hypomotile gallbladder. So obesity, estrogen, and rapid weight loss. Black pigment stones come from an unconjugated bilirubin load, chronic hemolysis, cirrhosis, cystic fibrosis, Gilbert syndrome. Brown pigment stones are different again. They come from stasis and infection inside the bile ducts. Bacteria deconjugate bilirubin. It precipitates with calcium. Think biliary strictures, parasites, and the post-cholecystectomy patient. If you take one slide from this video, take this one. About 80% of people with gallstones are and stay asymptomatic. Among those quiet stone carriers, biliary pain develops at 1 to 4% per year. And once a patient has become symptomatic, the rate of complications runs about 1 to 3% per year. Read that as a pooled figure. Acute cholecystitis is the dominant complication and runs higher, about 20% within 2 years of the first attack. So symptoms are the switch. Before symptoms, the yearly risk is genuinely small. After symptoms, it climbs, and it keeps climbing. Those 3 numbers are what the operative decision is built on. Put those numbers to work. We do not screen for gallstones with ultrasound. There is no population to screen and no benefit to find. An incidental stone on a computed tomography scan is a finding, not a diagnosis. And it does not explain a patient's chronic symptoms just by being there. And prophylactic surgery cannot beat a 1 to 4% per year event rate in a quiet gallbladder. So symptoms drive the operation, not the stones. There is a short list of specific exceptions, and we will get to it. Biliary pain has a shape and time. It begins abruptly. The patient can usually name the hour. Once it starts, it is continuous. It does not come in waves. It lasts 30 minutes to 3 hours. Then it resolves slowly, and it resolves completely. And it is episodic. Between attacks, the patient feels entirely well. That last feature does a great deal of diagnostic work. A patient with pain every single day for 6 months, with no well intervals, is telling you something other than gallstones. Now the shape and space. Biliary pain sits in the right upper quadrant or in the epigastrium. Either one, it may radiate through to the scapula. It is classically precipitated by fatty foods, which makes physiologic sense. Fat releases cholecystectomy. The gallbladder contracts against a stone in the neck, and nausea comes with it. Go back to our patient. Abrupt onset after fried chicken, epigastric. Steady, 2.5 hours, through to the right shoulder blade. With nausea, she matched every line. Now the naming problem. We all say biliary colic. The word colic means waves, cramping that builds and eases, like ureteric colic or bowel obstruction. Biliary pain does not do that. It begins abruptly and is continuous until it fades, steady. The second half of the name is no better. The pain is not always in the right upper quadrant. Epigastric pain can be entirely biliary, so if you wait for waves of right-sided cramping before you think gallbladder, you will miss patients like ours. Call it biliary pain. This is the distinction the whole case turns on. What points toward biliary pain? Discrete attacks with genuinely well intervals. An abrupt start, steady, lasting 30 minutes to 3 hours. Severe enough to stop the day, and radiation through to the right scapula. What points toward dyspepsia instead? Daily or near daily burning, bloating, belching, early satiety, and symptoms that ease with an antacid or a proton pump inhibitor. That difference matters enormously, because bloating and belching alone are not fixed by removing a gallbladder. So put her story against those two columns. 2 attacks in 6 weeks. Abrupt onset, steady. Epigastric, about 2.5 hours. Radiating to the right scapula, after a fatty meal, and completely well in between, plus a proton pump inhibitor that did nothing at all. Take a second before we answer. Which column is she in? And which single feature would you point to first if your attending asked you to defend it? This is biliary pain. The strongest single feature is the pattern. Discrete attacks with completely well intervals. That is not dyspepsia. Add the abrupt onset, the steady character, the duration sitting neatly inside the 30-minute to 3-hour window. The fatty trigger, the scapular radiation, and the nausea, and the failed proton pump inhibitor is a clue rather than a coincidence. Acid suppression does nothing for a stone in a gallbladder neck. Now we confirm the stones. On to the workup. It is short. 1 blood panel that should be normal, and 1 imaging study that is very good at this. The interesting part is what each abnormal result would mean. Laboratory studies are normal in most patients with biliary pain, and that normality is informative rather than disappointing. Renata sliver enzymes, bilirubin, lipase, and white count are all normal, which is exactly what uncomplicated stones look like. So flip it around. Abnormal laboratory results in this setting are your signal to go looking for a complication. A rising bilirubin or alkaline phosphatase points at a stone in the duct. A high lipase points at the pancreas. A high white count points at inflammation. Right upper quadrant ultrasound is the test. Sensitivity and specificity are both over 95% for stones larger than 5 millimeters. That is an excellent test, and it is cheap, fast, and free of radiation. 1 practical point that decides whether you get that performance. The scan should be done after a fast of at least 8 hours. Fasting leaves the gallbladder distended and full of bile, which is the background a stone shows up against. Scan a patient who just ate, and you get a contracted gallbladder and an unhelpful study. What if the story is convincing but the ultrasound is clean? That is where endoscopic ultrasound earns its place. In patients with biliary pain and a normal transabdominal ultrasound, its sensitivity is 94 to 98%. It finds small stones and sludge the surface probe cannot reach. And here is the pitfall on the other side. Computed tomography and a plain abdominal film are less sensitive. Stones without enough calcium are isodense with bile and are simply missed. So a negative computed tomography scan never rules out gallstones. Her ultrasound is done fasting, and it shows multiple mobile echogenic foci with posterior acoustic shadowing. The largest about 9 millimeters. The gallbladder wall is 2 millimeters. There is no pericholecystic fluid, and the common bile duct is 4 millimeters. Everything normal except the stones themselves. Combine that with normal laboratory studies and no fever, and you have symptomatic cholelithiasis without a complication. Classic biliary pain plus stones on imaging is an operative conversation. Now management. There is 1 definitive treatment. A short list of situations where you operate on a patient with no symptoms at all. and a couple of options for the patient who cannot go to theater. For symptomatic stones, the treatment is cholecystectomy, usually laparoscopic. And the phrase to remember is that sooner is better. Once symptoms have started, waiting simply buys more attacks and more chance of a complication. 20% of patients with symptomatic biliary pain progress to cholecystitis within 2 years. That is the number that makes the case for an elective operation. And notice the word elective. You would far rather refer this patient from clinic while she is well than meet her again at 3 in the morning. Here's the short list. Cholecystectomy in a patient with no symptoms is justified for a porcelain gallbladder, meaning a calcified wall, which carries a raised risk of cancer. For gallbladder polyps larger than 10 millimeters. For stones larger than 3 centimeters. For patients undergoing bariatric surgery. For cardiac transplant candidates. And for patients with hemolytic anemia, sickle cell disease being the classic example. Learn these 6, because everything else with no symptoms gets left alone. What about the pain in front of you? Non-steroidal anti-inflammatory drugs are the drugs of choice for biliary pain. Their efficacy is roughly equal to opiates, and they avoid the rise in sphincter of Oddi pressure that opiates cause. So they are the better tool on both counts. Reach for a non-steroidal first. And note what does not work. A proton pump inhibitor does nothing for biliary pain, which is why our patient got no relief at all from the one urgent care started. Some patients cannot go to theater. Ursodeoxycholic acid can be trialed for cholesterol stones with biliary pain, or in a poor surgical candidate. 2 caveats. It takes about 3 months to work, so it is not an answer to tonight's pain, and it only helps cholesterol stones. It also lowers the risk of gallstone formation that comes with rapid weight loss, which is worth knowing for our patient. And for patients at high operative risk, there are drainage options, percutaneous, or endoscopic transpapillary. Complications are best understood by anatomy. Follow the stone as it leaves the gallbladder. If it impacts in the cystic duct, you get acute cholecystitis. Inflammation behind an obstruction. 20% of symptomatic patients get there within 2 years. If it passes into the common bile duct, you have choledocholithiasis. And from the duct, there are 2 roads. Infection behind the obstruction gives cholangitis, and a stone at the ampulla gives gallstone pancreatitis. Each of those is its own topic. Today we name them and stop. 4 rarer complications worth the names. Maritzi syndrome is a gallbladder stone compressing the hepatic duct from outside, producing jaundice and biliary obstruction. A cholecystoenteric fistula is a stone eroding straight through the gallbladder into bowel. About 15% of those involve the colon. Gallstone ileus follows. A small bowel obstruction, usually at the terminal ileum, from a stone that traveled through that fistula. And gallbladder carcinoma, about 1% in the United States, usually found late, with a poor prognosis. 5 pitfalls. First, calling steady epigastric pain dyspepsia, which is exactly what happened to our patient. Second, trying to rule out stones with a computed tomography scan. It cannot do that. Third, scanning a patient who has not fasted and believing the result. Fourth, blaming an incidental stone for chronic daily symptoms. Bloating and belching will still be there after the operation. And fifth, operating on quiet stones with none of the 6 indications on that list. Each of these is common, and each is avoidable. So here is the assessment and plan. Symptomatic choledocholithiasis. 2 typical attacks of biliary pain. Stones on ultrasound. Normal laboratory studies and no fever, so no complication yet. The plan is referral for elective laparoscopic cholecystectomy. Sooner rather than later. A non-steroidal for a breakthrough attack. And stop the proton pump inhibitor because it is not treating anything. Return precautions matter here. Fever, jaundice, or pain lasting beyond a few hours. And we counsel her that rapid weight loss helped drive this. Let us close. Stones need 3 hits: cholesterol supersaturation, accelerated nucleation, and a hypomotile gallbladder. 90% are cholesterol stones and 10% pigment. Black pigment comes out of hemolysis and cirrhosis. Brown pigment comes out of infected ducts. About 80% of stone carriers stay silent, and 1 to 4% a year turn symptomatic. Ultrasound, after an 8-hour fast, is your test. Computed tomography misses stones, and you operate for symptoms, plus the 6 quiet exceptions. These are the sources behind what we covered. The European Guideline on Gallstones is the single best read if you want the evidence in one place. The dyspepsia guideline is worth a look if the distinction we drew today is one you make often. And cholecystitis, choledocholithiasis, and cholangitis each have their own video. Thanks for your attention.